So today I'm going to provide a definitive guide to how to interpret a CIMT scan report, carotid intermediate thickness scan report from the company CARDIORISK, which is the provider that I use myself and that I recommend other people use because they're a great provider and they operate nationwide. There is some nuance in terms of how to interpret these scans from CARDIORISK. So my objective in this talk today is to present that nuance and make sure you're crystal clear on how to understand your scan report. So let's just cut straight into it, okay? If you've been following my channel, you know the importance of getting these CARDIORISK CIMT scans done. So let's put up on the screen the scan I first had done with CARDIORISK in June of 2025, the one that gave me the spook, the scare. We'll go through them step by step because there's 4 individual risk elements that need to be assessed. The first element that needs to be understood is the headline attention-grabbing risk factor, which is your artery age. As you can see from my report, in June of 2025, when I was 57 years old, it is reporting my arterial age as being 78 years old, 21 years older than myself. And that's what people's attention focuses on. Are my arteries as old as me, older than me, or younger than me? And I'm going to get into the relative importance of this later, but for now, I just want you to understand what that is actually measuring. Your arterial age is derived from the number that is reported as your IMT. That stands for intermediate thickness. The two go hand in hand. Intermediate thickness is the thickness of the innermost and second innermost lining of the artery. The innermost lining is called the intima, the second innermost lining is called the media, and the scan goes up and down the carotid artery on both sides of your neck, and they take a mean, an average of the thickness, if you will, between the intima and the media, and that's what gets reported as your intermediate thickness, the overall mean of the average on both sides of that thickness. Now, intermediate thickness tends to increase as we age, and in the bottom left corner of the first page of a CARDIORISK scan, you can see the graph for men and women, and so they plot what is the typical or expected intermediate thickness at any given age. So you can see in the line going up from left to right. So my intermediate thickness, as reported in June of 2025, was 0.92 millimeters. You can see why they put the red dot above the curve. In other words, that thickness, 0.92 millimeters, is associated with a 78-year-old man. That's why I get the artery age of 78. And so intermediate thickness and artery age are the same thing in effect. When your intermediate thickness goes down, your arterial age goes down. When your intermediate thickness goes up, your arterial age goes up. So that's what intermediate thickness and artery age is. Now, I like to have everyone verify what I'm saying is accurate. So I just explained it to you in the way that I explain it, but why don't we have AI, my best friend Perplexity, explain intermediate thickness in its own words. Good morning, Perplexity. I hope you're having a lovely day today. I'm looking at a scan report from the company CARDIORISK. I'm talking about a CIMT, carotid intermediate thickness scan report. I want you to define what it means on the report when it says patient IMT, which stands for intermediate thickness. Just tell my audience what that is measuring.
Patient IMT means the measured thickness of the 2 inner layers of the carotid artery wall in that individual patient, the intima and the media. In plain terms, it is measuring how thick the artery wall is at the ultrasound site, usually reported in millimeters. For your audience, the simplest description is, it is a direct measurement of the carotid artery's inner wall layers taken by ultrasound, not a measurement of blood flow or blood pressure.
All right, folks, so that's the first part of the report. The second part of the report, the second risk factor, is what CardioRisk calls early event risk. And they give you a number and it's color coded. So you can see on my report that my early event risk number was 1.8 and they put that number in the box for normal and it's green color coded. Now, I need you to completely ignore the color coding if it's green. Don't ignore it if it's in the yellow or red, if it's moderate or high, but ignore it if it's green because that will give you a false sense of security. It'll imply and you'll feel like, well, my early event risk is good. Let's understand something. Early event risk is CardioRisk looking at the next 5 years only, give or take 2 years. That's all it is. So if you're green for early event risk, they're just saying, we don't think in the next 5 years, give or take 2 years, you're gonna have an event, a heart attack or a stroke. They're not saying you won't have an event 10 years from now, 15 years from now, 20 years from now. Just we don't think it's gonna happen in the next 5. I assume you're watching this video because you intend to live longer than 5 years, give or take a couple of years. I assume that not having a stroke in the next 5 years, or 7 years, or 3 years, while on some level is reassuring, it might be more reassuring to know it's not gonna happen down the line either. So it doesn't tell you that. It's just an immediate short-term thing. So forget the green. Now, if you're yellow, moderate, or red, high, that means they're literally saying, we think an event is coming into your life soon. Because the time horizon is 5 years, give or take a couple of years. So you can't ignore the color coding when it's yellow or red, moderate or high, but you need to ignore it when it's green. What you have to focus on with early event risk is the number. And you can see my number says 1.8. Now, that means I'm elevated risk. 1.0 is the reference risk number for a person's age and gender, kind of like the baseline hazard ratio, and I'm sure AI is going to nitpick with me on this. So as if you will, 1.0 is the quote-unquote normal risk. So if your number is greater than 1.0, that means you are at above average risk. You're doing worse than the typical male or female your age. If your number is less than 1.0, then you're doing better than the average person your age and gender. So the thing to focus on with early event risk is the number. Take no reassurance if it's green. If the number is greater than 1.0, but it's got green behind it, normal, that just means you're cruising towards a heart attack or a stroke. You're just not speeding towards it. And ladies and gentlemen, heart attacks and strokes, 1.6 million people in America will have them. Number one killer by far. Number one thing that maims people. Who do you think it happens to? It happens to people who are at above average risk for their age and gender, and that's what you are if your number is greater than 1.0. Now, you can fact check me on this with Perplexity AI, so I just said it to you in plain lay speak, but just to be thorough, let's have AI give its technically correct explanation for what early event risk means. Perplexity, next I need you to define for my audience what early event risk means on a CardioRisk CIMT report. They give a number, and my understanding is that any number above 1.0 means that the person is at greater relative risk than the typical person, that person's age and gender. Whereas if someone is less than 1.0, it means they're doing better, relatively speaking, in terms of risk compared to the typical person, their age and gender. My further understanding is that the green color-coded for normal event risk and moderate and high refers to a 5-year time horizon only, give or take a couple of years. Tell me if my understanding is correct, and be nitpicky if you like, and be specific for what early event risk and the color coding means.
Your understanding is mostly right, but there are two important nitpicks. Early event risk on a CardioRisk CIMT report is best understood as a relative risk estimate based on the largest IMT measurement, not a direct prediction that an event will happen. CardioRisk describes it as the chance of an adverse cardiovascular event over about 5.1 years, with a stated variation of plus or minus 2.3 years. A value of 1.0 is the baseline reference point. A value above 1.0 means higher relative risk than the reference group, and a value below 1.0 means lower relative risk than the reference group. The reference is not just typical people the same same age and sex in a simple everyday sense. It is a risk model anchored to the lab's comparison framework, and as described in cardio-risk-related material, it is tied to age and gender, plus the report's risk calculation. What the colors mean. The green, moderate, and high color bands are a risk category system, not a separate measurement. In the material I found, the early event risk estimate is explicitly framed as a roughly 5.1-year horizon, so your about 5 years understanding is accurate, with some wiggle room around that estimate. A precise way to say it, for your audience, you could say early event risk is the report's relative risk score for the largest carotid IMT measurement, showing whether the result is above or below the reference level for someone of similar age and sex, and the color coding groups that estimate into normal, moderate, or high risk over an approximately 5-year time frame. One subtle correction, I would avoid saying any number above 1.0 means greater relative risk than the typical person that person's age and gender, as an absolute rule, unless you are quoting CardioRisk's own reference model directly, because the score is a model-based hazard risk estimate.
There you go, folks. I told you it was going to nitpick. Yeah, it reminded me, actually. CardioRisk, the way that they come up with it is a little bit of a proprietary model that they use. They look at the thickest part of your intima media thickness. There's a number, right? Left-hand side, right-hand side. They go, where's the worst part, the thickest part? And then they take that number and they correlate it in with a Framingham risk analysis based on age and gender. And that's how they come up with this early event risk number. And in simple terms, if your number's greater than 1.0, relatively speaking, it's not cool. My number was, what was it? 1.8. That's 80% worse than the reference risk for my age and gender. So let's move on to the third risk category, right? And this one gets really technical, okay? And I've yet to have any medical doctor explain this correctly. So I'm going to explain it to you correctly, and we're going to use AI again. And that is average CCA max region. All right, here's how they come up with that number. You've got your common carotid artery, or arteries, one on each side, CCA, common carotid artery. They go to the left-hand side first, or maybe the right-hand side, and they look at it from 3 different angles. The sonographer, the technician, holds the device and asks the following question in each angle. Where is the worst, the thickest little region, intima media thickness, I can see in this angle? And then what's the maximum peak in that little region? Then they look at it a second angle, same artery, just to see if they can see the worst area from another angle. And then they do a third angle. So on the left-hand side, they're going to end up with 3 different numbers, all looking at the same thing in 3 different angles. The thickest, worst little region in each angle, and the highest peak of those little regions. Then they're going to go over to the right side of your neck, the right CCA. So they're going to end up with 6 numbers. And then they average those 6 numbers. And that, ladies and gentlemen, is what constitutes the average CCA max region. That's what it is. Again, let's have Perplexity fact check this, and I guarantee you Perplexity is going to get nitpicky with me on this. Perplexity, my darling, next I need you to define what is meant on a CardioRisk CIMT report by average CCA max region. I need you to tell my audience exactly how that number is calculated and what it means to be in the normal, moderate, or high risk category.
Average CCA max region on a CardioRisk CIMT report is the mean of the maximum intima media thickness values measured in the common carotid artery regions sampled on the scan. In plain English, they look at the thickest IMT point in each measured carotid region, then average those peak values together. How it is calculated? The report's average CCA max region is not the same as the plain average IMT across the whole artery. It is a mean of maxima. First, identify the largest IMT value in each sampled CCA region or view. Then take the average of those largest values. CardioRisk-related explanations describe this as taking the biggest readings from the different views and averaging the peaks. What it means? This number is meant to summarize the largest thickening or plaque-like prominence seen in the common carotid artery, rather than the overall wall thickness everywhere. That is why it is often described as a mean max or average of the peaks. Risk bands. A CardioRisk-related explanation gives these cut points for the average CCA max region. Less than 0.75 millimeters is normal. 0.75 to 1.0 millimeters is moderate risk, and above 1.0 millimeters is high risk. One nitpicky clarification, because this is a peak-based measure, it is more sensitive to focal thickening than the plain mean IMT, so it is not just a second way of reporting the same average number.
There you have it. It's looking at the worst thickness parts of the peaks. All right, the fourth and final risk factor on a CardioRisk scan report is the most important, and we're going to get into relative importance of these risk factors in a second, and that is plaque burden. Plaque burden is reported as one number, and you can see from my report in June of 2025 that my plaque burden was 3.1 millimeters. Let me explain how that plaque burden number is calculated, because you need to pay close attention to the fine print on your report. You need to go down to the comments section. And in the comments section, in small print, will be 6 numbers. You can see it says right CCA 0.9 millimeters. Bulb on the right side, 1.8 millimeters with the letter H next to it. Right internal carotid, 0.7 millimeters. On the left-hand side of my neck, the common carotid artery, CCA, 1.1 millimeters. Bulb, 1.3 millimeters with the letter H next to it. Internal carotid, 0.8 millimeters. Ladies and gentlemen, from these 6 numbers in the comments section is how they calculate and tell you what the plaque burden number is in the color-coded section. The way CardioRisk defines plaque is to look for any area of intermedia thickness that is greater than or equal to 1.3 millimeters. And if they see an area that is greater than 1 or equal to 1.3 millimeters of thickness, they're going to give it the label plaque. So when you're looking at the comments section, they're measuring 6 specific points, 3 on the left side, 3 on the right side, for intermedia thickness. So if you see 1.2 millimeters in any of those numbers, that is not going to get reported as plaque. But if you see 1.3 millimeters or higher, it's going to get reported as plaque. And if there's more than one number that is greater or equal to 1.3 millimeters, then those numbers get added together, and that is what constitutes the color-coded plaque burden. It is the total number of lesions, if you will, that are greater or equal to 1.3 millimeters, as seen in the comments section, added together. So if you've got a number, let's say that's 5.8 for plaque burden, that doesn't mean you've got one plaque lesion of 5.8 millimeters. It might be multiple lesions that add up to 5.8. So that's why looking at the 6 numbers in the comments section is so important, because it's that feeds into the plaque burden number. And 1.3 millimeters is a little bit of an arbitrary cutoff. It's kind of like, at some point, when do we go from saying something is just thicker than it should be to calling it plaque? CardioRisk say 1.3 millimeters. Other companies might say 1.6, I don't know. Think of it like this. It's like when you do your HbA1c blood test, you know, they tell you that like normal reference range is 5.6 or lower, and then pre-diabetes is 5.7 and above. Well, think about it, right? The body isn't really different between 5.6 and 5.7, but at some point there's got to be a cutoff, right? At some point they got to go, right, pre-diabetes. So it's kind of like that philosophically with CardioRisk's choice of 1.3 millimeters. That's why even if you have no plaque in the color-coded section, you got to pay attention to those 6 numbers. Because let's suppose, hypothetically, all 6 numbers said 1.2 millimeters. What's going to happen in the color-coded section is it'll say normal, no plaque. They're all 1.2 millimeters. So imagine the next time you get the scan done 6 to 12 months later, every single one of those 1.2 millimeters is now 1.3. You're going to show a massive amount of plaque in the plaque burden number, because there's going to be 6 lots of 1.3 millimeters all added together. You see my point? It's a bit like, you know, if you go get your HbA1c blood test done and it's 5.1, and then 6 months later it's 5.6, you're still going to be normal. You're not going to be told you're pre-diabetic, but your train's going in the wrong direction, isn't it? So from one scan to the next, you got to look at the numbers in the comments section. Which way are they moving? Even if they're not yet at 1.3 millimeters. Anytime they find a 1.3 millimeter or greater lesion, that's what I'll call it, they put a letter next to it. And there's 3 options. There's S stands for soft, H stands for heterogeneous, and E stands for echogenic. And that's the nature of the plaque, the nature of the lesion. Soft plaque, heterogeneous is mixed plaque. It's still non-calcified plaque, but it's a little more stable than soft plaque. And then you've got echogenic, which is calcified plaque. So you've got soft, mixed, and calcified. They just call it soft, heterogeneous, and echogenic. That's what that means. And of the types of plaque, the best one to have, if you're going to have any, is echogenic, E, calcified. The most dangerous type is if you see the letter S, soft. That's like a pimple ready to burst. It's not good news. H, heterogeneous mixed plaque, is that in between. It's neither soft nor calcified. It's mixed. And that tends to be what a lot of people have. It's still non-calcified though. It's not complete concrete. It's not as stable as calcified plaque. There's risk to having non-calcified mixed plaque, okay? So plaque burden is the most important part of the cardio-risk scan report. I'm not going to ask Perplexity to explain plaque burden to you because the way I just explained it is 100% correct. Okay, I don't even need Perplexity to get nitpicky with me on this. It's from the 6 numbers. You got to look at the type of plaque that it is, and you got to measure the trend in those 6 numbers. Now, the 4 things, so let's rank them in order. Of the 4 risk factors, we've got artery age, which is intima media thickness, the mean. We've got early event risk, we've got average max CCA region, and we've got plaque burden. In order of importance, numero uno, by far, is carotid plaque burden. The total plaque burden, and then the breakdown of the plaque lesions in the comments. Rules the day by far. I don't care what your IMT is, your intima media thickness, your artery age, the color-coded headline attention-grabbing thing. If you've got a lot of plaque lesions, okay, you're at great risk. Doesn't matter what your color-coded early event risk number is if you've got plaque lesions and they're soft or mixed. Plaque lesions are what rupture and can kill or maim you. It is by far the most important thing. If you pay no attention to anything else on your CIMT report from CardioRisk, pay attention to plaque burden and the 6 numbers that feed into it. Super important. And we will check this. We will fact check this. The second most important thing I would argue here, this is where I'm opining a little bit, is early event risk number. Forget the color coding unless you're moderate yellow or high red. Then they're telling you, they're predicting something bad's coming to your life soon. If you're green, no. If you're above 1.0, you're at elevated risk, and you need to knock that number down. The third most important thing in terms of priority is IMT, the mean of your arterial thickness, okay, your artery age. It's the thing that gets the headline attention on the top of the report, and it's the third most relevant thing. And the fourth is this average max CCA region. To me, it's kind of just looking at the same issue as mean IMT, but from a slightly different perspective. It's just measuring the worst of the worst peaks. I mean, typically, you would expect that number to go down when you reduce your IMT and your artery age. So it's related. I've never seen discordance between those. In other words, your IMT, your artery age is high, your mean, your peaks are going to be high, kind of go hand in hand. But plaque burden is what matters. So let's check this with Perplexity as to what matters, because it frustrates me that this scan is called carotid intima media thickness scan, which focuses on IMT, when in fact it's not IMT that matters that much. It's plaque burden. So plaque burden is a component of a scan that's called CIMT. I wish they called it carotid plaque burden scan, because then people's head would get in the right place. Because what's happening right now, too many people say, oh, my artery age is good, that's good. Oh, look, color-coded green for early event risk, I'm fine. And then they don't pay attention to the details, the little 6 numbers in the comments section that literally determine the most relevance for whether or not you're going to potentially live or die or be maimed for life. But let's check Perplexity on this. Perplexity, good morning. We've just covered the fact that there are 4 different risk components to a CardioRisk CIMT report that need to be analyzed. First, we've got artery age, which is mean IMT. Then we've got early event risk. Then we've got average max CCA region. And finally, we have carotid plaque burden. 4 different risk factors. Of those 4 different risk factors, which one does the scientific literature state is the most relevant to pay attention to in terms of assessing one's risk of a heart attack and stroke?
The most relevant of the 4, based on the scientific literature, is usually carotid plaque burden. In general, plaque is a more direct marker of established atherosclerosis than IMT-based measures, and reviews have found that plaque predicts coronary and stroke risk better than CIMT alone. How the 4 stack up? Carotid plaque burden is most clinically specific because it reflects focal atherosclerotic disease rather than just generalized wall thickening. Mean IMT or artery age is useful as a marker of arterial wall thickening, but its standalone predictive value is usually more modest. Average max CCA region is another IMT-derived measure, so it still reflects wall thickness, but it is not generally considered more informative than plaque when actual plaque is present. Early event risk is a derived risk estimate from the scan model, not a direct anatomical finding. What the literature says. A major review concluded that CIMT independently predicts coronary and stroke risk, but its prediction of CHD was inferior to carotid plaque, because plaque may better represent atherosclerosis. Later work also showed that plaque-related measures can outperform IMT in event prediction, and combined plaque plus IMT measures may add more than IMT alone. Practical interpretation. If your audience wants the single most important thing to notice on a CIMT-style report, it is usually whether plaque is present and how much plaque burden there is. IMT-based numbers still matter, but they are better thought of as supporting context rather than the most disease-specific signal. A careful wording would be, among these four, plaque burden is generally the strongest and most direct marker of atherosclerosis-related risk, while the IMT-derived measures are more indirect wall thickness metrics, and the early event score is a model-based risk estimate.
All right, folks, there you have it. Now you know what to focus on. Listen, the reason you're on my channel is why. I got this scary report in June of 2025. Since then, I am regressing and improving all four elements: arterial age, IMT, early event risk number, average max CCA region, and plaque burden. I'm doing it in a relatively rapid fashion. You can get my reports, my progress, by downloading the files in the description box to this video. And my goal in going through this with you is that you don't have to waste money trying to have these things explained to you. So if you like my content, please do subscribe. Leave a comment, because it helps feed the algorithm to get this information out to more people. And as always, please go get the scan. Don't argue with me. Just go to cardiorisk.com and sign up to get the scan. I'll catch you next time.